Because for every medical error that they don't commit, that goes back to whoever is paying for the care. For every time that that patient is not sent to a higher level of care setting, that they're kept in a more appropriate, a lower level of care because they've been managed well. A practitioner doesn't make any money off of that. Frankly, sometimes they make less money off of that. So we've realized just how difficult the incentives is. I think it was Jim Reinertson that spoke one time to the Midwest Business Group on Health. He'd put in 17 different guidelines. There were clinical guidelines. They were going to follow them to the letter, standardized care. You know how important standardization is to quality. He was going to standardize that care, and they were going to look at outcomes, both cost and quality outcomes. Well, Jim got up that night at that celebration, Business Group on Health there, clinicians there from all across his system at Park Nicollet. He said, we've had a really terrific test here, and I'd love to tell you that's an unequivocal win-win for all of us. He said, we put these 16 guidelines in, followed them to the letter, delivered care through electronic means to people, did not call them into our clinics. He said, but I can tell you that it's not an unequivocal win-win for all of us. He said, I have one particular clinic, a 10-physician clinic, that's lost $100,000 this year on urinary tract infections alone, because I only get paid when the patients show up. So every step we take toward this idea of collective nirvana is one step my clinic takes toward insolvency. So the payment system does not support our improvement right now. So in looking at that, no wonder, here we are behind every other industrialized nations practically. It's just an embarrassment where we stand with electronic medical records, and we wonder why. We don't have to wonder. We're not, when a person gets 11% of the return on investment, no prudent business person in their right mind is going to go put something in place and get 11% of the return. I've got this in handouts for you that are on the internet, on your website, and I just wanted to let you know that some of the programs and incentives here, this is just great. It totals about $34 to $36 billion in investment. It's really exciting to begin to see the infrastructure start to be put into place. Meaningful use of EHR technology by community physicians will net them about $44,000 per physician. If you've got a high Medicaid population, that's going to go up to about $63,000 per physician if you're able to meet meaningful use criteria. 10% increase for health professionals in shortage areas, except not for you. You don't get to enjoy any of those incentives. Now, those are the Medicare incentives. Here's the Medicaid incentives, and they get even payment for adoption. They don't just get incentives once they've already installed and they're meaningful users, but $8,500 a year for 5 years to maintain it, $63,750 for adoption. How exciting. Not for you. How did this happen? I looked at and I think, how in the heck did that happen? So to me, this is just, it just screams for leadership. We have got to have happen at the national level what's happened to us in Rhode Island. Somebody grabbed me by the scruff of the neck and said, you don't get it, and began to sit me down and talk to me about what it was going to mean to my community and to my state if I left the big gaping hole in terms of the services that you provide. And I think we have a big gaping hole here. Now, the good news is I do sit on the National eHealth Collaborative Board on the national level, and I intend to take this message to the national stage so people can hear this. And I'll just finish up in the last few minutes here with just a little bit more information about this kind of a case study of what we're doing in Rhode Island, why this has been so profound for us and how it all got started. So in case you're thinking about something that might be going on in your community, I can assure you there is a health information exchange going on in your neighborhood somewhere. These are all over the country right now, and if you're not involved, that was the first stop I would make when you get home, is find out who's leading that and find out why you aren't involved if you're not. Applaud it and support it if you are. So our regional activity in Rhode Island, now I was going to say we like to refer to it affectionately as Little Rhody, but actually everybody outside of Rhode Island likes to refer to it affectionately as Little Rhody. We have 1 million people in that state. We have 13 acute care hospitals, 2 psychiatric hospitals, and we have about 3,000 physicians in the state. It's a little petri dish. If we can't do something important in the state of Rhode Island, we should be slapped, because this is just so small. It's 35 miles by 45 miles. We have line of sight trust. If we can't do something that models something for the nation, then what a tremendously lost opportunity. So what happened here is that our Rhode Island Attorney General, Sheldon Whitehouse, got ready to run for governor. And so he began to form this thing called the Rhode Island Quality Institute. He called together the highest-ranking CEO, highest-ranking leaders from insurance, health insurance, from the hospitals, from consumer rankings, from physician leaders, state government, lieutenant governor, the DHS secretary, the Department of Health director. And these were the highest-ranking, most powerful people he could find. Pulled those people together, and then I think they worked for a couple of months, and finally he called a friend of ours named Don Berwick and said, Don, we're not getting any traction. Can you send me somebody? And I got the call from Don, who said, I'd like you to go down here to Rhode Island, and here's this guy. And I said, Don, this hurts. This guy's a politician. He's running for office. He's probably trying to create a storefront. I'm not going. He said, I don't know, Laura, I think this is different. I think you should go down there and check it out. When I walked in the room and I realized that he really had amassed every major stakeholder, and most of the people were there, they were so dead honest with me. They said, no, we're not here because we think we can make a difference, because we think this thing's going to last. We think this guy's got a way better than average chance of being the next governor. That's why we're here. And I applauded their honesty. I was delighted with their honesty. But when I looked around and I realized that this guy has pulled together people who are basically natural enemies in the wild, and I'm looking at them thinking, I don't know how he did this. They don't want to breathe the same air, and they're in the same room. I love it. So I thought, if we don't screw this up, this could be really remarkable. So it blossomed into this idea of this non-for-profit statewide, because Sheldon didn't make it through the gubernatorial primary. He didn't make it through the Democratic primary, which was wonderful for us because it made us sink or swim on our own. We were not going to be a governmental agency. We were out there as a true public-private partnership that had to demonstrate our own worth. It was a big gift. Sheldon went on later on to become the U.S. Senator from Rhode Island. And so that's really, really helpful to have someone like him. And believe me, along with Patrick Kennedy, Sheldon Whitehouse understands this. He understands your role in it. We will make a difference in this for you and for the people that you serve. My family, too. Not-for-profit was really important. 24 board members all across the board, all sorts of different. We have one person, one vote. So our patient from the inner city community health center that sits on our board has the same vote as the largest integrated delivery network that covers about 60% of the market share in the state of Rhode Island. So it's a very, very level playing field. Lots of consensus, high levels of participation beyond the board. And here are the principles that Sheldon set out for us in the very beginning. He said, we're here to produce real results. He said, this is not going to be a think tank. This is not going to be another place where we're going to produce another white paper. We're not going to collect up a bunch of data and hope somebody else acts on this. He said, if we don't like the performance of this system in this state, and we don't, who do we think is going to change it? Think the federal government's going to swoop in and fix this for us? Not likely. He said, we're the leaders. We have our hands on the levers in this state. If we don't like it, shame on us. It's up to us to change it. So this was a sense that we were going to produce real improvement in consumer-focused care in that state. Collaboration, he said, I realize that you people can't stand to breathe the same air. I don't care about that. When we get in here, he said, I think that's nonsense in the first place. When we get in here, we're going to focus on serving the people that live in this state. And if you don't like that, you can leave now. Fortunately, no one did. And then he talked about focusing on system improvements that no one can achieve alone. Not one of us can achieve alone. This is when I started looking at information technology, because I thought that is the one thing that when we get the system knit together, it requires virtually every one of us to work together. It was the only thing that I could see that covered every single player in the state was the information technology. We're going to be transparent. Oh, this was so important. We have consumers that ring our boardroom at every board meeting. Our board meetings are open to the public. And the effect, I think, of having consumers sitting in the room, people that we serve sitting in the room, has been an incredible effect of having our behavior made public. And I'm not saying that people wouldn't have behaved honorably, ethically, and in the interest of patients and consumers if they hadn't been there, but it really helps. That's probably Ben texting me again. He probably wants to go home again. So with the consumers viewing our behavior and all the decisions that we're making, not done in some back room, but being done publicly, just caused people, I think, to go that little extra mile to design it to be consumer-centric. And then senior leadership required, he said one more thing, don't send your lieutenants. Too many times he said we get one of these things going in the state, and it's great because the first few meetings you've got the kahunas there and everybody's woo, it's makes the news and all that, and then 3 months from now you're sending your assistant director of landscaping in your place.